Good afternoon and welcome to today's complimentary webinar on maternal health disparities, confronting racial inequities, presented by IAMHP and Cayaba Care. My name is Judith Ruiz Branch and I'm the Director of External Affairs here at IAMHP, or the Illinois Association of Medicaid Health Plans. As a member organization for the Medicaid Managed Care Health Plans, IAMHP works with Illinois state government, legislatures, advocacy groups, and Medicaid patients to invest in and provide high-quality health care focused on cost-effective, individualized care that helps the residents of Illinois live longer and healthier lives. Improving health care outcomes, however, takes partnership and collaboration, and that's why we are so excited to welcome one of IAMHP's newest trusted partners, Cayaba Care, to join us for today's presentation. Before I introduce today's esteemed presenter, I'm going to quickly run through some logistics. As you can see, IAMHP utilizes the GoToWebinar platform. So a GoToWebinar control panel should have popped up on the right-hand side of your computer screen if you are logged in via your computer. This is important to note because this is how you will be interacting with today's webinar. If at any point you have any questions or technical difficulties, please feel free to use the chat box or questions box to communicate with me. I'm coming up as IAMHP admin/organizer. Please note that we have saved time at the end for questions and answers, and we will also be sending out a post-webinar email that will include materials from today's presentation. So without further ado, I would like to introduce today's presenter, Dr. Mary Fleming from Cayaba Care. Dr. Fleming is an experienced OBGYN and the co-founder and senior clinical advisor at health tech startup Cayaba Care. She provides direct clinical care as a physician across the country and has strengthened her practice by serving as a medical legal consultant, physician editor, and president of the nonprofit Reed Scholars, Inc. Dr. Fleming completed her undergraduate degree at Xavier University of Louisiana, medical degree at Vanderbilt University School of Medicine, and her residency in obstetrics and gynecology at Meharry Medical College. Due to her interest in eradicating health inequities and improving health care for the underserved, she matriculated to Harvard Medical School as a Commonwealth Fellow in Minority Health Policy, where she obtained a master's in public health from the Harvard T.H. Chan School of Public Health. So now I am so excited to turn it over to Dr. Fleming.
Hello and good afternoon. Thank you again for the invitation and the opportunity to share a little bit about maternal health equity and what we're doing at Cayaba Care. Just kind of as a little bit more background about Cayaba Care, which we'll spend some time delving into a little bit more at the end of the presentation. But we are a maternal health startup that's located in Philadelphia. And we really wanted to think a lot about how we could reimagine maternity health care and prenatal health care to address the most vulnerable populations in our country. And we'll talk a little bit today about maternal health equity and some of the things that are facing our nation right now and how we're trying to address it. So with that, I want to bring up something that's been in the news recently, not to really discuss it, but to kind of give a backdrop around the challenging issues around maternal health. And so many of you probably know the statistics around maternal mortality in this country, and Black and Brown women are at increasingly higher risk of dying during their pregnancy and during the year immediately after delivery. And so one of the recent comments as made by Senator Cassidy, who's also a physician, is that when we look at those numbers, if we discount the number of Black women in the statistics, then our numbers wouldn't look so bad. And so of course there's more to the story, and I'm not going to go on to the whole story, but this gives the backdrop around how Black women in this country are viewed and how we're treated, how we are often overlooked and not counted, and that only intensifies the level of health equity disparities across the board for Black women and their health outcomes in this country, but it's only underscored during the maternity period. So with that, we can just give a little bit, you can move to the next slide, a little bit of context around maternal health disparities. So we'll start with just looking at health equity in general. I will go over some terms and definitions. And again, this is just a conversation starter. We won't have all the answers at the end of this presentation, but at least a lens on where solutions can lend themselves. We'll talk just briefly about some of the issues specifically around maternal health equity right now, and then strategies and mechanisms to try to address these inequities. So when we think about health equity, we think about what really addresses our health outcomes. And we know that our health outcomes are often influenced by things that are outside of the four walls of the hospital or the clinical space. Our health is influenced by systemic issues. And so we've talked a lot about racism in the context of the healthcare system. We talk about place matters, where we live, our zip code really influences our health outcomes. We talk about how we're interacting on a day-to-day basis. How are we getting to work? Do we have employment? Do we have access to insurance? Do we have somewhere to live that's stable and safe and free from environmental factors that might influence our everyday living? If we are employed, do we have enough money to actually take care of ourselves and our families? And so when we can't think about our overall health outcomes without thinking about those things. And this diagram kind of gives you an idea of how much happens outside of the health system, where the overall interactions or overlaps happen. And when we think about solution and interventions, it's important to know where these disparities happen, and that's how we know where to direct our interventions. And so I think a lot of times we think of we need to talk to the providers, which we do, but that's only a small part of our problem. We're really thinking systemic issues. How can we change the way the groups of people are interacting with the system, and what are the community contributing factors that they're going back to that are overall going to be bigger influences on their health outcomes. So with that, we'll talk a little bit about these definitions. So like I said, these are all definitions that come from other people other than me. But when we're thinking about how to optimize health equity, we have to think about those terms individually and collectively to figure out where we're trying to get to. So starting with the first one. Equity. What does equity mean? So for a lot of times, we have the adage, especially in the United States, all men are created equal. What does that mean? And when we talk about equality, does equality actually lend itself to equity? And the reality is not. So when we're not starting at an equitable playing field, we can't just divide the resources evenly and expect the outcomes to even out, right? We have to place the correct resources with the correct need, and so that everyone can be enable everybody to optimize their outcome. So we're thinking about equity as being fair and impartial in the way that people are treated. Got to go into the next thought around health. So now we think about, okay, so we're trying to be fair, we're trying to be impartial, we're trying to make sure that everybody has the resources that fits their need. And then what does health actually mean? And so, we talk about historically health is the absence of disease, but really we're trying to get to optimal health. We want your full person to be healthy. So not just your physical person, but also your emotional, social, spiritual, and intellectual person. So thinking about this in a more holistic framework. And so that, again, outside of what's just happening in the clinical space. So then we put these phrases together, right? So there's, you can go to the next one. There is health care equity and health care equity, right? Which sounds very similar, but are slightly different. And so when we think about the health care we receive as individuals, but also the health care equity that we receive in the system, right? And so we're not just thinking about, we often think about the system that we operate in now is not really a system that was built to address the diversity of the population that we serve now. And you think about the historical healthcare system that was fragmented, that's not equally funded, that did not equally serve certain populations. So we think about our safety net hospitals, which are different from our tertiary Care hospitals. And we think about historical, why those hospitals were built and how they were funded, was because there was a fundamental difference in how people were served in our country. And those things are still fragmented and haven't been brought back together. So we want to provide healthcare equity as far as we want everybody to get the appropriate services that meets their needs in a fair and just way. But we also can't just think about the individual receiving that care. We have to think about the system in which that care is being given. And so I'll leave you with a couple of definitions from some of our thought leaders around health equity. And I think these are important. I don't usually like to read from slides, but I think these are important enough to read out loud. So from the Commonwealth Fund, our nation's legacy of racism is embedded in our healthcare system. For many people of color, this legacy has meant less access to quality care and poorer health outcomes. We research and promote the policies and practices needed to achieve an anti-racist health system where people of color can thrive. And I think, as these conversations have evolved a lot in the past few years as we have been confronted with more and more social justice issues on a national level. And so as we think about not just acknowledging that racism is a part of our systems, but how do we actively change it and work against it as opposed to just understanding that it's there and navigating around it. And so from the Robert Wood Johnson Foundation, health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education, and housing, safe environments, and healthcare. And so I think that's a little bit more comprehensive on the challenges around health outside of the healthcare, outside of the clinical space, in trying to maximize everybody's opportunity to live as healthy as possible. So with that, we're going to transition just a touch. I'm going to share two videos with you, or a video and a portion of a second video. And the reason why we're sharing these videos, so one of them is a little old, but it gives us a little context of why maternal health inequities are so powerful in the stories. It gives you a little bit of a story to tell and understanding the context. So with that, and some of you may have seen this video in the past. Like I said, it's a little old, but I think it's still, the sad thing is most of these things are still the same. So we'll go with the first one now.
The biggest myth about racial and ethnic disparities in infant mortality is that people think that this has to do with just socioeconomics, and that the disparities are really the consequences of racial difference in socioeconomic status. And it isn't that simple.
Infant mortality among white American women with a college degree or higher is about 4 deaths per 1,000 births. But among African American women with the same level of education, infant mortality is about 10 per 1,000 births, almost 3 times higher. In fact, African American mothers with a college degree have worse birth outcomes than white mothers without a high school education.
Think about this. We're talking about African American doctors, lawyers, and business executives, and they still have a higher infant mortality rate than non-Hispanic white women who never went to high school in the first place. So what I've been calling for is rethinking of an old problem from a new perspective, and to really rethink racial and ethnic disparities in birth outcomes from a life course perspective. And simply put, the life course perspective posits that birth outcomes are the product of not simply the 9 months of pregnancy, but really the consequences of differential exposures across the life course of women of color. We know that racism is stressful, and we know that stress can impact on health in many different ways. It creates this chronic wear and tear on your body's systems to adapt. It wears on the hormonal system, and wears on the immune inflammatory functions, it wears on your metabolic functions, and over time creates an overload on all of these organs and systems so that they no longer function optimally.
Everyday racism is like gunning the engine of a car without ever letting up. In fact, people who've looked at blood pressures, measuring ambulatory blood pressures for white folks and black folks, young folks, see that the blood pressures might be the same during the day, but at night the white folks' blood pressures would drop. The black folks' blood pressures would stay the same. And so it is. It's like gunning the engine of that car, just wearing it out without rest. And I think that the stresses of everyday racism are doing that.
And then if you were to carry that into the pregnancy, then that gets embedded in both the pregnancy physiology of the mother and the developmental biology of the child. We certainly have done a lot in terms of increasing access and utilization of prenatal care, especially amongst communities of color, and yet we've done very little to reduce prematurity rates. I think that the problem is that with prenatal care, you're trying to cram all these good things into less than 9 months of prenatal care, and then expecting everything to turn out all right in the end, and to expect prenatal care in less than 9 months to reverse all the cumulative disadvantages and inequities that's being carried forth over a life course of differential exposures. Is probably expecting too much of prenatal care. So if we're serious about improving birth outcomes and reducing disparities, we got to start taking care of women before pregnancy. And I'm not just talking about that one visit 3 months preconceptionally, talking about when she's a baby inside her mother's womb, and an infant and a child and an adolescent, and really taking care of women and families across their life course if we really want to do something about improving pregnancy outcomes.
So that I think gives us a good backdrop onto understanding where where we are around maternal health disparities and what the disparities are, and just kind of a brief snapshot. The next video gives us a little bit more insight into a singular person's story. And this is a little bit more recent, and there's been a little bit more recent traction on this in the news lately, so you may have heard an update. But this particular video follows a particular story and the challenges that are continuing to exist, and a little bit of insight from the experts as well. This video, we won't watch the whole thing, but clearly it's available on YouTube for you to go complete if you want to watch it at a later date. But we'll start with this one.
Can it possibly be true that women giving birth in our country are more at risk than women in dozens of other nations around the world? Afraid so. Erin Moriarty has the stories behind some terrible statistics.
So, Mommy, where you at?
Beautiful Palm Springs. Fearless is how Charles Johnson describes his wife, Kira. I love you.
We're talking about a woman that was a marathon runner, that raced cars, that was a skydiver.
It never occurred to him that the greatest danger Kira would face would be going to one of the best hospitals in California to have a baby, their second son, Langston.
Hey, Mommy.
Hi, Daddy.
Hey, Langston. For us, we were really and truly expecting this experience the second time around to be a walk in the park.
It was a C-section, not because there was a problem, right?
They suggested that you had one before, and they recommended that she have another cesarean. Hey, Langston. We're waiting on you, buddy.
The first sign of a problem came in the late afternoon of April 12, 2016, shortly after Kira gave birth.
I was sitting by Kira's bedside, and I began to notice the catheter turn pink with blood.
I was when it costs a little less. A doctor ordered a CT scan, a CAT scan. Johnson says he didn't worry at first.
Something's not quite right, and I was aware of that, but we've got a plan. And she's in what I thought were great hands.
And how's Kira feeling during this?
Lethargic. I'm continuing to advocate and ask more adamantly, look, when are we taking her for the CT scan? Well, 7 o'clock rolls around, 8 o'clock goes by, 9 o'clock comes, 10 o'clock comes.
There's still
no CT scan.
Shortly after midnight, his wife was taken into surgery.
She's holding my hand and she's saying that she was scared. And I'm telling her that everything's going to be okay. Everything's going to be okay. And that was the last time I saw my wife alive. When they took Kira back to surgery, there were 3.5 liters of blood in her abdomen. And she coded immediately.
When you say code, she died.
Her heart stopped immediately.
Kira Johnson was 39 years old, and her death isn't just a personal tragedy. She's part of a disturbing national trend.
The United States is the only industrialized country where the rates of maternal deaths have increased, not decreased. And so young women actually have a higher risk of dying during pregnancy and childbirth than their mothers did.
Dr. Marianne Etiobet is executive director of Merck for Mothers, a program run by the pharmaceutical giant Merck to reduce the number of maternal deaths throughout the world. She never guessed that one of the countries most in need was the U.S.
60% of the deaths in the United States are preventable.
And where do we compare to other developed countries like Great Britain, Canada?
The United States is ranked 46 when it comes to maternal mortality. That's behind countries like Saudi Arabia and Kazakhstan.
In the U.S., that means at least 2 women are dying every day. And it's not just deaths on the rise. So are near deaths, 60,000 a year across the country.
When it was happening, it would go on from anywhere from like 15 minutes to an hour. It felt like my body just wanted to crumble.
Amber McLaughlin was 29 years old and 8 months pregnant when she began to feel an excruciating pain that would come and go. She says her doctor wasn't alarmed. They're telling you, no, don't come in. We've seen you. You're fine.
They told me to go home and rest. They said, you're 35 weeks. You're probably uncomfortable. Go home and rest. And I said, not going home. I'm coming in today.
Even then, a nurse practitioner hesitated and then relented, sending McLaughlin for tests.
I get hooked up to the monitors, and a few minutes, I mean, it felt like 2, they came rushing in and they said, where's your husband? This baby has to be out in 10 minutes.
She had developed a rare condition that caused her blood pressure to skyrocket, putting both her life and her baby's at risk.
I'm thinking to myself, I was right this whole time. Why has it come to this? And so at that moment, even at 5 years later, it's one of those things that when nobody believes you.
When McLaughlin's son was delivered by emergency C-section, he weighed just 3 pounds. Was there a time when you really wondered whether you'd ever get to see your son?
That first day, he was really struggling. I mean, they told us that he was at pretty close to the end.
Was your life ever at risk?
Part of when I was saying, quote unquote, I think I'm dying, that's because I truly believe that my kidneys and my liver were starting to shut down.
So what's causing this spike in maternal deaths? There are a number of factors. More women wait until they're older to have babies, and often they begin their pregnancies less healthy, with chronic conditions like obesity, high blood pressure, and diabetes. But some medical professionals say the real problem is how those babies are delivered. They blame much of the increase in deaths and near deaths on a dramatic rise in C-sections.
If you have a C-section in 2018, you have a 90% chance of having a C-section the second time. But the second time, it's a more complicated surgery. And the third time, it can be like operating on a melted box of crayons. And in those cases, women can bleed to death.
Dr. Neil Shaw is a professor of obstetrics at Harvard Medical School.
The pain is okay.
And a practicing physician. Are you also saying that some of these C-sections are just not necessary?
Probably more than half of them.
And when complications do arise, says Dr. Shaw, Doctors don't always listen to their pregnant patients.
I think there is a dimension of gender discrimination. If a woman after a birth goes into a hospital with concerning signs of a complication, there are no rules for how quickly an obstetrician has to see her. And in fact, it's a routine case that it will take hours.
And statistics indicate that it may not just be gender that plays a part in dangerous delays, but also race.
If you're a woman of color in this country, especially if you're Black, your odds of dying in childbirth are 3 to 4 times higher on average in our country.
Why? Because you're not talking about access to healthcare. You're not talking about money or education.
No, and this is going to be hard to hear. We believe Black women less when they express concerns about the symptoms they're having, particularly around pain. And that's the common thread in all the stories we've been hearing in the media, including Serena Williams.
Yes, even Serena.
We'll stop here. I know this is a captivating video.
Embolism after giving.
But I don't want to take up too much of our time, but I would encourage you to go watch the rest of it. And so just kind of transitioning back to our presentation, when we talk about, the videos raised a few important concepts, right? I really wanted to underscore the concept of a life course, and especially the life course in maternity care. So when we think about interventions at this particular stage in a person's life, we're not just thinking about interventions for that individual, but we're thinking about interventions that will affect the community over a length of time, because that person has the capacity to reproduce, and what's happening in real time in the pregnant person's health will influence that pregnancy and then that person in the future. And when we think about the context of historical structures in the United States, then, we think, oh, the United States has been around for a long time. And in the grand scheme of the world, it has not. And in the grand scheme around race dynamics in this country, it's been a very short amount of time since the civil rights era. We can think about ways in which social justice issues have been underscored in the past couple of years, as COVID has highlighted that there are still some gross inequities around racial lines in this country, and those are not excluded from the healthcare system. And so these two, and we won't spend much more time on this, but I wanted to kind of give a context around what the framework looks like, particularly for this country, for the United States, and what our history has influenced, but also the ability to not change just an individual's life outcomes, but also that of their children. So just a couple more slides, we'll go through some pregnancy-specific causes of mortality. And so we mentioned in the video that cardiovascular disease is a major cause of health disparities in both Black and white women in the country. And just kind of give a backdrop for those who haven't done a lot of work around health disparities research. A lot of our research is really dichotomous in Black and white, because that's the historical data that we have from years ago. But know that this issue is not confined to these two populations. When we look at other women of color, especially those from the Latinx community, that's also very diverse in and of itself. And the AAPHI community also has an alarming number of health disparities, but for historical data and comparison, these are the two populations that we often use. But the maternal mortality causes are not exactly the same amongst the two populations, and they diverge for several different reasons. But just to give you an idea of what causes things to happen during pregnancy that can lead to maternal mortality. And then we also talk a little bit, and again, this kind of gives some context because of the historical nature of our country and how people have come and gone over the years. And so I think we have the unique ability to try to understand, is this an American problem? Is this a Black American problem? Is this a white American problem? And so sometimes we use information around new immigrants to this country to push back on the idea that this is DNA or genetically motivated. Of course, there are some things that are biologically driven. However, most of the things that are truly influencing health disparities, again, are those things that happen outside of the healthcare system that are driven by systemic disparities that we can counteract. So well, again, we won't spend too much time on the numbers, but just want to give kind of a sense that to push back on some of those myths around that these things are biological. So what do we do? I think, this is an overwhelming problem. Oftentimes when we think about how do we address such a huge problem and it's such a diverse problem? And I think again, you have to break things down in pieces and work on it the best that you can. I'm listing a few different strategies over the next couple of slides. Again, I'm not going to read all these to you, but we talked about this life course perspective again. And so there's a time, if we're organizing around maternity, there's a time before pregnancy, during pregnancy, and after pregnancy. And each of those give an opportunity for intervention around optimizing health and medical conditions prior to pregnancy, making sure people are on their right doses of medication and have optimized their weight, and making sure that they understand about pregnancy. We can also include contraception in this conversation, right? Because we want people to be pregnant when they want to be, and not because they don't have another answer. And there's many ways to interact. So we talk a lot about the individual. We talk about a lot about the healthcare system, but not to the extent that we want to leave out the individual. So there's definitely individual things that we can do to make it better. But we can also intervene on the community and health system levels as well. So increasing education, thinking about things that influence your neighborhood outside of the individual family. So this is the environmental and factors about where people live. What do they have access around transportation? Clean water, healthy food, and that type of thing. And then, of course, moving on to the healthcare system levels. What are the systems that are in place? How are we collecting data? What are we doing with the data? Who are the people who have access to our system? Or is everybody accessing our system in the same way? What are the biases that are interjected already into the system that can be identified and addressed? So there's multiple ways, and these things typically all need to be done simultaneously when possible. And the next couple of slides are going to look very, very similar, right? So it's, similar things, but during pregnancy. And as we once we transition to the last part of the presentation, we talk a little bit more specifically about Cayaba Care and what we're trying to do. Again, we're trying to help address these issues from as many different ways as possible. So you'll notice some stars on these slides, and these are ways that Cayaba Care specifically is trying to address some of the disparities that exist in healthcare for the pregnant population. And so it's not just making sure that they have adequate clinical care during the pregnancy course itself, but making sure they have connections to services that would help them have an optimal pregnancy, like WIC and Medicaid, and making sure they have access to transportation to and from their appointments, helping them understand what's going on during the pregnancy so that they are empowered to ask questions. And we talked a little bit about in the videos on how people are listened to, and so trying to help empower them with the right information that they can advocate for themselves. And then also just understanding from a systems level, understanding what the challenges are to these particular populations and how we can intervene on that level. How can we partner with organizations like yourself and other organizations in healthcare providers, payers, and other advocacy groups that are working for this population so that we can try to change some of the narrative around maternal mortality in this country. The next slide, again, is going to be pretty similar, thinking about during the labor and delivery process. So some of these catastrophic things do actually happen during the labor and delivery, and we talk about communication and access. But, a lot of things, that's a very small window. And we want to do a lot before, the patients even get here, and making sure they have continued support after they leave their small clinical intervention around delivery. So switching over to Cayaba Care specifically. So I mentioned we are a maternal health startup that was founded in Philadelphia, and we just kind of for historical context, the three of the founders, we all had some familiarity with the area and had worked there previously. We know that the area had a need that we could target specifically, and so we wanted to start there. When we planned to move past there, but we wanted to start there. And our program is built around a position called a maternity navigator. The maternity navigator is a person that's going to help us meet pregnant people where they are. So they're specifically trained to work with this population. They're trained to help with improving not just education around the pregnancy, helping to facilitate clinical appointments and that type of thing, but also working with that trust and trust building with the system and helping the advocacy and empowerment angle. We hire them specifically from the neighborhoods that they serve so that they have a familiarity with the community and what the community needs, and that we hopefully have already taken a level of trust just because they're familiar with the community and the patients. And these maternity navigators are supported by a host of people, including nurse practitioners, OBGYNs, lactation consultants, social workers, and behavioral health specialists that are inside of our organization itself. And then we also are connected to community resources outside of our organization to help facilitate these wraparound services for our patients. The services that they receive, again, are designed to meet them where they are. So it's a combination of both in-home visits and virtual visits, depending on what's going on in their particular life and how we can best serve them. And again, we're trying to decrease their competing priorities, is what I like to say. And so if they're dealing with other children at home, or they're dealing with an aging parent, or they're in between employment, then we can help facilitate some of those burdens by meeting them where they are. Again, we won't spend much time on this, but we've had quite a number of positive reviews over the past few years almost. That we were founded in 2020. It doesn't seem like it's been that long. In the midst of the pandemic, we're starting a company, but you know, in the age of Google reviews, kind of it explains where we are and how well our patients have received us. So our maternity navigators are very well received. Our nurse practitioners do amazing comprehensive OB care. So we've had a ton of positive patient feedback, and we hope to continue to do the same. So one of the things, like I've mentioned, is we're trying to be very purposeful about creating a environment that serves the people, that employs people to serve people who look like the people that we serve. And that's important because again, as we talk about historical factors, as we talk about trust in this country, as we talk about understanding the nuances at the community level, I think it's important that we hire people that are also sensitive to that regard. And so, again, we've been very purposeful about hiring people who have clinical experience in communities that have challenging communities, we'll just say that, and making sure that we're being as culturally sensitive and appropriate as possible. So it's a whole company atmosphere. It's not just it's just not optics, if you will. So just a few, again, we're relatively new, but we have seen some positive outcomes already. Right now, our women everything is free to become a member of our program, so they can self-refer, but most of our patients are referred from other healthcare systems. And then, of course, we take their insurance and some for no out-of-pocket expense for them. Again, we pride ourselves on patient satisfaction, so we don't want to just improve health outcomes. We want the people who we serve to feel like they're getting a value add and that they are satisfied with their care. So we survey them often and make improvements based on those results to make sure that they continue to have an optimal experience. The goal, of course, is to make sure that they are meeting their clinical milestones. So going to their visits as appropriate, getting their lab work as appropriate, so that if a medical indication arises, that we can intervene early and try to decrease the risk of adverse outcomes at any time during the pregnancy. And the other thing that we've noticed is, and this is not unique to the maternity population, but those who don't have regular care, who don't have established providers, who don't access the healthcare system in an efficient way, we'll say that, I will often use the emergency room for care. And so one of our goals is to make sure that they are supported so that they don't use the emergency room for non-emergency problems. So that's one of the things that we are excited that we have worked on doing already thus far. With that, I think we did a lot in a little bit of time. And so if you all have any questions or anything you want follow up on, you can definitely feel free to ask me any questions at this time. Of course, for those of you all who are interested in learning more about Cayaba Care, you can visit our website or follow us on our social media platforms. And then, like I said, for the videos, I would definitely recommend kind of finish watching the second one, just for a little bit more in-depth stories around the topic. So with that, I will conclude my remarks.
Thank you so much, Dr. Fleming. That was amazing. I'm just still digesting all of that information. But we have a question from Amber. I'm just going to read it because she did say that you partially addressed this during the presentation, but in terms of Cayaba Care services and reimbursement through Medicaid, not sure if you can answer this, but she was just curious how those services are typically covered at Cayaba Care.
Yeah, so it's a combination, I think, or an evolution, but there are multiple ways that reimbursement can happen. So at the basic level, then we can still bill fee for service for certain visits. Again, because we have nurse practitioners on our team, and when our patients see, it's a clinical visit like any other clinical visit. So it would be billed as a fee for service visit through Medicaid. And that's one plan and one possibility. As we continue to build partnerships with other payers, then we may be a value add to a bigger system, and then we would be more of a pay by quality, pay per member situation. So it's just, those conversations are kind of evolving. So can't give you too many details as those partnership conversations are still in the works, but those are the two basically big buckets.
Perfect, thank you. And I know, Dr. Fleming, that you guys are not based in Illinois, but as you know, for IAMHP at least, we do cover the entire Medicaid healthcare system in its entirety for the state of Illinois. Can you talk a little bit about the legislation that's passed here recently for the continuity of care when it comes to Medicaid members, and kind of how Cayaba Care is looking to maybe expand services here in Illinois?
Yes, I probably can't get, again, too specific, but kind of two thoughts around that question. So one, again, we started in Philadelphia because it made sense, and we thought that there was a need in that particular population. As we look to partner with other locations, it's kind of the same thing. Like, we're looking for places that are have a need, who are looking to intervene in this particular patient population, and have some, we have to build partnerships and support, right? And so who are amenable to building those partnership and support in those particular particular location. Secondly, in thinking about expansion of this particular model, so we think, we really describe ourselves as reimagining maternity care and pediatric care. And so not just stopping at the end of the postpartum period, but influencing what's happening way past the postpartum period, right? So again, talking about legislation and rules around when does the postpartum period end, when does Medicaid coverage end, and going beyond that 6-month mark to the year mark, when we know that there are still some ongoing clinical needs and behavioral health needs and that type of thing, I think would be advantageous for all of our patients. And then that would be the next normal step for also including some increased pediatric care, because again, that first year of life is crucial for making sure that our kids start off well. So I think those are kind of the two thoughts around expansion, locally as far as geography is concerned, but then also clinically past the pregnancy episode.
Thank you. We did have another question. They wanted to know, they are a CNM, and would like to know about your organization incorporating doulas possibly into your program.
So that's a great question. We're actually talking a little bit more about that this morning. So our maternity navigators, a lot of them are doula trained. And so we wanted our maternity navigators again to be, most of them started out as medical assistants because they do need clinical experience. So they're going to be doing the blood pressure checks. They do blood draws. They do some injections, both in the office and at home. So we do need them to have clinical expertise. But a lot of them are also cross-trained in a lot of different ways. So whether that's doulas, lactation consultants, they usually come with some other training because we need them to also be maternity specific, right? And we want to lessen the burden of the amount of additional training we have to give them when they first come on. So it's nice when we can find people who have already been maternity trained and generally have a second set of certification. But we were talking about whether, we've talked back and forth on whether we want to expand the doula lane for the program, but we are definitely doula friendly. And we think that doulas play an important role in the pregnancy process. We're not a doula program, if you will, at this point. We don't provide delivery support right now, but we are sensitive to that need and are thinking about ways in which we can partner and collaborate to incorporate more doula interaction, if you will, during the pregnancy journey.
That's great. Thank you, Dr. Fleming. This is a question that I also had when I first learned about Cayaba Care and the model that you guys have. We have someone asking about funding because we know that your membership is completely free, which is amazing. So they're curious about program funding.
Right. So right now we are, we have funders. So we have venture capitalist funds that helped us start and are maintaining us through these first several years. But we will be the point is to be revenue generating at some point. So that transition will happen as we continue to make partnerships, like I said, with either healthcare systems or payers. And so that funding stream will change to be a revenue generating organization at some point. But our point is to be as accessible to as many patients as possible for no out of pocket expenses for our patients. So that's the goal.
Yeah, and it's so important for the populations that we're talking about as well. When we talk about legislation, which we touched on a little bit, in terms of putting actual policies into practice, a lot of times there seems to be a lag or a disconnect. How have you found, or do you have best practices that you can speak on or touch on in regards to closing that gap of, you have this great legislation and policy that's passed, but how do we actually implement it and then turn it into a model that will improve health outcomes?
Well, that's $1 million question, my dear. I think the challenges are on many levels. I think, what we're trying to do is build a sound model that is both, gives great patient satisfaction, improves outcome, and is reproducible and scalable so that we can take it to different markets. So as legislation is opening and more amenable, then we can say, hey, there's this great model that's proven, and we can scale it to your particular population, and it's going to increase your outcomes, and patients love it. So that's what we're trying to do. I think, when you're having conversations with partners, I mean, you still have to understand the landscape of American business, and still a capitalist society. So we also have to understand, and a lot of people always ask about the revenue, right? Because, or the funding stream, because that's important, right? It's great to have optimal healthcare outcomes, but we also have to worry about the bottom line. And so I think about, when we have conversations, how do we make this mutually beneficial? And we know when you take better care of people, you're going to reduce your healthcare expenditures. And we can have a whole nother conversation on another day about health expenditures in this country. But and even when you think about something simple around decreasing maternal morbidity during pregnancy, that might decrease NICU stays after delivery. That's going to decrease the bottom line of hospitals and healthcare systems. So finding a mutually beneficial outcome that's both clinically important, but also important for overall health expenditures or community benefit, or, you can go down the list about finding things that are mutually beneficial, but I think we have to find a commonality that everyone can wrap their mind around, and then try to move the needle.
Great. Just a couple more questions. I know we are running out of time, but I could seriously continue this for another hour.
And you were worried I wouldn't have any questions.
I know. So we work a lot in the Medicaid space in trying to address social determinants of health. Can you just talk a little bit about how that comes into play with Cayaba Care's model, and being able to come into people's homes and kind of establish those trusting relationships, and maybe break down some of those barriers that they might be experiencing in more clinical settings?
Yeah, so that's really where we started, right? That's kind of our guiding, one of our guiding principles is really starting with understanding what the social determinants of health are for a particular population, and how we can decrease that burden as much as possible. Our maternity navigators they are phenomenal, and they really do a good job of introducing themselves, again, understanding where the patient is coming from, describing our program and what it involves, and how it is, again, mutually beneficial for the patient and their family and the community, and how we can help navigate them through the pregnancy course. And again, it's not just the clinical stuff, right? It's like, oh, you can help me get on WIC. Oh, you can help me, I'm having trouble getting to my appointment. You can help me with transportation. Oh, I just lost my job. You can help connect me to resources for rental assistance until I get a new job. It's, oh, I really want to see you, but I can't get there. I'll come to you, and we do virtual visits as well. And so sometimes it's, the housing situation might not be the most stable, or we know that our patients don't often live by themselves with their immediate family, so they might be living in a group home situation or with extended family, and it's not always the best time to come in. So we'll have phone calls, we have video chats. They can text our maternity navigators if they need them in between visits. So we try to make sure that they know that we are available, and I think just being available and listening, it goes a long way. And then being able to help negotiate some of those nuances around having access to care is helpful. And they know we're there for the continuum, right? So once they enroll, that we give them kind of a roadmap on what to expect as they engage with us. And so I think that also helps them to know that we're supporting them along the way. But there's also education, and they know that we're trying to make sure that they understand what's going on. We're not talking at them. We are engaging with them to try to make sure that they have the best outcome as possible. So I think it's multifactorial. And then, like I said, we have all the wraparound services around clinical needs in-house, so that it's not waiting to find out from something else. So if we have an acute need with the maternity navigator, she can call the nurse practitioner who can hop on the line, or lactation consultant, or we're working on dietitian and nutrition as well. And then the social workers are phenomenal working with our population. And then we have a referral to a psychiatrist built into our system that we can use. So I think it's having as many things in-house as possible to make the referral as efficient as possible also helps. So they're not waiting a month, right, to have a needs addressed. We can do a lot of things almost in real time.
Yeah, that sounds really similar to kind of the managed care model that our health plans have adopted. And it's amazing the impact it can make. And this topic hits very close to home. So if you hear a baby in the background, please excuse that. Our last question, and I'm sad that it's our last question because I really enjoyed your presentation, Dr. Fleming. But as we think about the evolution of health equity, I guess one question that comes to mind, it kind of stems around implicit bias as well, because IAMHP has worked on legislation surrounding implicit bias and the importance of that when it comes to addressing maternal morbidity in this country and in this state. And so when we look at the evolution of health equity, the statistics that you shared with us today in terms of, the numbers getting worse and not better over time is kind of jarring. And so can you just kind of close us out by talking about that evolution of health equity, what we're seeing, and kind of, what we hope to see moving forward?
I will say there is a moment or a lane for understanding that some of the numbers that we are seeing are also because we're doing better about reporting, right? And so there has been some improvement around data collection, but to that point, it could have been actually worse before, right? We didn't have the data to follow it along. But I think once we recognized it was an issue and started collecting data around the issue, then our data has continued to improve. And so I think we now have these numbers that are like, oh, this is actually really happening. And so I think that's one thing. I think implicit bias is an important part of the conversation, and I think we have to talk about it in the grand context of the conversation. But I hesitate to spend too much time on thinking about individual interventions because I think the problem is systemic. And so, yes, we can train individuals to be more aware of their biases, but if we're still operating in an entire system that's biased, that's not going to change our outcomes as quickly as we would like. And so I think it's a both and situation. I think, some of it is just the reality of where we are. And of course, we won't get political with this, but we are becoming more polarized as people. And so I think that it makes it a little bit more challenging as individuals understanding someone else's point of view and being sensitive to that. I think it's always been easier to attribute things to a DNA problem, to a biological problem, to a behavioral problem. So, you did this, so this is why these things are happening to you. And it's more challenging to address things on a systemic level because they're so multifactorial and can be overwhelming. So I think as we shift towards understanding these, where these issues lie on a systemic level, then we'll move faster, quicker. But as they say, you got to name a thing before you can address it. And I think we're just getting to that point where we're actually naming a thing, so that we can address the systemic issues.
Absolutely. All such great points to end on. So thank you so very much, Dr. Fleming, and thank you to Cayaba Care, our trusted partner, for joining us today for this complimentary webinar. To learn more about IAMHP and watch other helpful webinars like this one, we encourage you to visit our website at iamhip.net, and we hope you enjoy the rest of your day. Thank you so much.
Thank you again.